We continue to learn, continue to refine our pre-implantation genetic testing to learn what's safe, what's not safe, to gain as much information as we can so that we can identify which embryo in that petri dish is capable of resulting in a live birth.
We had a patient who I think would have probably made you question some of my expert acupuncture skills, as she had 7 day 3. She had 7 eggs, and she suddenly had this drop off, and you knew that she was working with me and that I was prescribing herbs. And so you picked up the phone and called and said, hi, I'm glad you're helping our patients, but I'm just curious, what's in these herbs that she's taking? And I was like, well, she hasn't had a bowel movement in 7 days. And I put in some rhubarb and some purgatives and things because I think she needs to do that. You were like, well, all of her eggs are going away. And it was this, we will never know, was it the herbs or her body? Right. And
Right.
so you must have
been. We're so focused on, the science and we monitor our patients very carefully, and we're very careful about the dosing that we use because we want all of the recruited follicles to grow and develop and to make sure they grow evenly. So we put all of our energies into trying to make that happen. So if we find something unusual, they stop growing or they're getting smaller, that's a concern. So for us to hear that she's drinking a lot of herbal teas, one has to question, is there something that may be inhibiting the development of these follicles?
Yeah.
So that, I think that's what initiated the call.
Yeah.
What's Danica doing
Yeah,
to these
right.
follicles?
What is going on? Yeah.
Right.
And that, I think, would be the last time that I used any kind of clearing method. And I became very cautious of using herbs during the ovarian stimulation phase.
But as you said, we'll never know. I mean, maybe they were not healthy follicles, and that's why they did not continue to grow.
Mm-hmm.
Because in the beginning of the cycle, we typically do ultrasounds on day 2, day 3 to look for all the recruited follicles. We measure their sizes, but some of those could be left over from the previous cycle. They may not be newly recruited follicles. So we really have to watch the growth and development to know what we're working with.
Mm-hmm. Down to the 0.5 millimeter. Right?
We're obsessed with the size of our follicles.
I know that. Thank God for the technology, but I can't even get my head around how small these follicles are and the nuance of their sizing for the triggering and the protocols.
Well, we're very careful to get the maximum number of eggs, follicles to maturity without overcooking them. We don't want to do anything that could potentially lower their quality, especially in our patients who have a small number of eggs. And in women in their late 30s, early 40s, we want to make sure that the follicles don't get too big, because the ovaries, the eggs are a little more fragile, and we want to get them out, with the least amount of medication, the least number of days of stimulation, but yet have a usable mature egg to work with.
Right. And to not overcook it and denature the DNA.
Right.
Right.
Well, we all put a lot of energy into try to get the best outcome for our patients.
Yeah.
So,
we should let the listeners know that particular case did have 6 of the 7 follicles fall away, and you wanted to cancel her cycle. She came in and told me that, and she started hysterically crying. But then I watched this really interesting transformation of her sitting on the treatment table, where she suddenly was like this dragon, fertile goddess warrior woman who was like, I've always been a survivor. Nothing has been easy in my life. This one egg is my sole survivor, and I'm going to insist we put it in. And that turned into her son. So it worked.
That's fantastic.
A happy ending. But side story is that to help her prepare, she and I had gone through a lot of discussion about the way she was raised, in an alcoholic home, she was abused. There was a lot. So to see those 6 drop off, I didn't really feel like, oh, this is an herbal thing. I felt more like this is a woman who presents as tough on the exterior, but inside really is fragile. And as it turns out, like, we had those important conversations. That's the work that goes on over here.
Well,
right?
that's what's so fascinating, all the additional information that you receive from the patients,
Mhm.
that we don't see, maybe because, we don't take the time to listen to it, or they're not in the position to give it.
Right. And they really shouldn't. They go in for those appointments with you, and it's about counting and measuring eggs and then adjusting the protocol. That's what goes on over there. I'm not doing egg counts over here. I'm not doing retrievals and surgeries and procedures. I'm in here talking to them about their fears, doubts, worries, their past attempts, what went wrong, trying to help them figure out what we can do different or better, or how we can strengthen them, or how we can bring back some hope or some healing in the process. So what I thought was the funniest about that particular case is I got to see her come into this flourishing, empowered patient. And maybe like 6 years later or something, when I had my kids, we were in the aisle together at Toys R Us. And I felt somebody staring at me. And I looked over and I was like, mm. And instead of her saying, "Oh my God, Danica, thank you so much for your help," she just looked and like turned and walked away. And I was like, okay, you know what? That is fine. I understand. There's a lot of women that don't want to remember this time of their life, and I'm not going to take it personally. It is what it is. It all worked out. But these are the behind the scenes things going on in the nuance of this field of medicine.
Yeah. No, for many individuals, this treatment is so private, and I learned early on in my career, don't say hello to someone in a grocery store, a patient, unless say hello first, because many of them don't want to be potentially identified as an infertility patient.
Mm-hmm.
So
yeah, it's true.
So it's nice that you give them this safe space to talk, right?
Mm-hmm.
And to tell their story and their fears, and because it can only help in their treatment.
Yeah.
Even
right.
though they're telling you it's helpful to me because maybe she's releasing it all and she's, right?
Mm-hmm. Yeah, for sure, because it's energy. And until acupuncture and energy is scientifically explained, we really don't have the conversation established well enough to know what that means and how to wield it into a successful fertility outcome. So it's sort of like, oh, this is forcing this thing called integrative medicine, where we do our energy woo-woo stuff and you guys do the down to the millimeter and the milligrams of the dosing of the medications, right? And then
Right.
the patient is in the middle. And ironically, that's how I earned my doctorate, was this idea of SeedFertility as an IVF intervention for a model of patient empowerment. It was, remember, you were recruiting patients there to the study.
Exactly.
So it was like, can this online program that we designed to mimic what was going on in the CFP lobby when I used to do the live workshops. It was, can the videos that these patients have supplied and the videos that I made teaching them about the 4 phases, can that be helpful along with changes to the food and using food as fertile medicine? Can they take all of that information and change their outcome? So they never met me. All of the participants in that study were doing acupuncture somewhere else. So they were already going to acupuncture and had been trying for 2 years. There were only 10 women. It was a small cohort, but they had 33 eggs in their collective, their most recent IVF cycle. So like an average of 3 eggs each. They were poor responders.
Right.
And then they also had only, among all 10 of them, one woman had one normal embryo that she had made. So they were, by definition, not very fertile. So they went through the IVF intervention, the seed program, and afterwards they had a total of 58 mature eggs retrieved, and they got 3 normal blastocysts.
Fantastic.
Yeah, so that was a measurable outcome.
Right.
But those 3 normal embryos turned into live births. And 2 other women in the cohort said that they appreciated the value of the mindset change so much that they were ready to use donor eggs. So of that cohort that I know of, 5 of the 10 are mothers now.
Fantastic.
Yeah. So it was like, we need to explain that information, because it's the doctors and the acupuncturists working together to empower patients. And in one of the videos, you were featured and you were explaining, well, you tell us.
Well, what's
what
so
did you want them to
beautiful
know?
about what you're describing is these women are feeling empowered, that they have some control back. Because when you're experiencing infertility, you're frustrated, you're sad because something that should be so natural, just to get pregnant, is not happening. And so you feel this loss of control over your reproductive status, loss of control of your body. And then you go see your doctor, and your doctor tells you to inject all these hormones because we're going to push your ovaries. So you've lost control of your ovaries. We're pushing them with hormones. And so that can lead to some negative energy, I would imagine. And we want the opposite. We want your positive energy helping the ovaries to help us. And so by empowering women to take some control over this process, led to positive results, right?
Mm-hmm. Yeah. It seems so logical now, looking back at it. I would not have even attempted that if I didn't know that that was how the results were going to play out after. Gosh, I started that in 2018. So I had 17 years of experience and personal experience of seeing when we adjust things in this way or that it changes, and like 40 to 50% of the time, it improves the outcome.
So are the changes, how much are due to the empowerment theory? How much is due to dietary changes, or how much is due to the acupuncture? Mm-hmm. Do we know?
Mm-hmm. Well, the statistician who analyzed my data, she used a test called the Wilcoxon sign rank test to say there's so many different variables going on, but the number of eggs, mature eggs, and the number of embryos and the live births, that there was just such, given that these weren't like average IVFers who had, like 12 to 15 eggs.
Right.
And then
no, these are low responders.
So to count a small amount and to see it double across the board, that was measurable. So that was how they did it. They said, with this many different variables, we can't see which one it was, but we cannot deny that it was a useful IVF intervention.
Fantastic.
Yeah. So I'm proud of that. That was a lot of work. A lot. But anyway, all in good, all for a good cause.
Oh, but it really was continuation of the work that you had been doing, and it was just a documentation of the impact that work has.
Yeah, I needed to do it for myself. I needed for the medical community to see that it was something, and maybe I'll repeat that study and recruit more women, but right now it's good enough for me.
Great. And you're continuing the seed program?
Well, yeah.
From that?
So there's now, so we should say that we should let the listeners know that you were actually the one who named the program. Remember, we
were trying to come up with a name that was appropriate. Mm-hmm. And as you said earlier, this program started, really the origin was your work with Joyce.
Yeah.
And we talked about how Joyce practiced. We also talked about Joyce's love for her roses in her garden.
Mm-hmm.
And she would often refer to, when she was doing ultrasounds of patients' ovaries, she would refer to them as rose gardens. And let's see what's blossoming today in your ovaries.
I didn't know she was doing that, but you knew.
Yeah, I heard about it from her patients. Oh, let's see how the garden is doing today.
Uh-huh.
And so it had to be something sort of garden-like, rose-like, and reproductions. So seed popped into my brain, and it seemed like an appropriate,
it was
title.
Perfect. Yeah, because seed also is about potential, right?
Potential for new life.
New life. And inside of a seed is where all that new life is, and it's invisible. We can't see it, but it's obviously there because you put it in the soil and put sunshine and water, and then somehow the intensity inside the seed reaches some kind of optimal condition, and then it cracks the seed coat open and a sprout comes out, right? I mean,
beautiful.
I just can't, we take it for granted, right? But that is what that program is about. It's all about helping women recover their fertile potential. So knowing that that was what I was going to provide, I wanted to call it like Spirit of a Mother. And you said, well, actually, it needs to be available for gay men couples and their surrogates to use, which to this day, there is still not one of those cases that I know of using the SEED program. But the term really stuck and explains on so many different levels.
And is the program popular today, the SEED program?
Yeah. So it's been featured on different podcasts. So it's now in 38 states and 15 countries.
Amazing.
Yeah. Seed sprouts up on all other episodes.
Okay. Okay.
But I'm so grateful that you took a chance on me and this kind of medicine and saw the value that it had in the patient population. Like you could have just said, well, Danica, we'll talk about it. You and Dr. Marks both could have just blown off the conversation, been too busy. But instead, I think it was your amount of respect for Joyce and
for you, and we always look for answers. Our patients want answers. Well, why isn't this working? What's wrong? And we look for answers in science, and science doesn't have all the answers. There's still some significant clinical problems that we can't solve, like low ovarian reserve. Well, why is it happening? What caused it? Why can't we reverse it? We don't have all those answers. So we need to add in other thoughts, other ideas, your ideas, and, redirecting this inner energy towards something positive.
Yeah.
And it worked, right?
Yeah.
And
Yeah.
it's still working.
Right. Well, it worked for me as I pulled Joyce aside back in 2002 or 3 and said, I have an elevated FSH score of 21 points and I'm 31 years old. What's the secret sauce? What do you guys do when that happens? And she was like, we don't have anything. And still, because the ovaries have as many eggs as they're going to have, but really FSH isn't a true indicator of egg reserve, but it was all the markers that we had at that time.
Correct.
So it was definitely enough to get me.
It's really a later marker. A high FSH means the reserve has already decreased significantly.
Yeah, right. So I was really in trouble. Depending on how I was going to look at it, I was going to be in trouble.
But then what happened?
So I had a pity party. I felt really scared, honestly. The doctors couldn't help me, but I started thinking, well, I have all these herbs. I've got this pharmacy. How lucky am I? I have this knowledge and I have 400 single herbs and I have an inquisitive nature. So I have some experience helping these other women and maybe I will just figure this out. And so I was optimistic and I spent 6 years doing acupuncture, doing herbs, going through relationships that weren't good. And I had this intuitive voice talking to me. I'm Kira Connors, I'm coming to you. And that was the last name of her dad, right? So a lot of intuitive stuff plays into how I roll, how I help the women, how I helped myself. So I had to get the courage to listen to my voice louder than what science was saying and tell myself to believe that it could happen and that if it was meant to happen, nothing would stop it from happening. So when I say things like that and my patients hear that, then are your patients, then you maybe see them come back and they are a little bit happier or a little bit more upbeat, positive minded, trusting.
Yep, absolutely.
And then you say, so then I suggest they go into the SEED program and then they watch movies and they see you saying like the changes in the diet, we are seeing it make a difference, right?
And what's really wonderful is the way you share your personal story to help inspire others. I think storytelling is so important in this field because many patients feel alone. They're the only one suffering and they don't, it's private. They don't want to talk to anyone. So to hear these positive stories that didn't start out positive, but ended up positive is really important.
Yeah, because it helps them to think actually
about what could be possible.
Yeah.
I have a really cute story about telling stories.
Oh, please.
I think, as you know, about 5 or 6 years ago, we presented an award to Sir Elton John and David Furnish for sharing their story about family building. And it was a big Us Weekly magazine article. And just went through the whole process. It was very beautiful because their lives were changed dramatically with the birth of their sons.
Yeah.
So one day I get a phone call from this woman in Norway. She was at the grocery store checkout line and she saw this Us Weekly magazine cover story about Elton John and David Furnish. And all of a sudden a light bulb went off. She said, they had a baby through surrogacy. Maybe I can too. Because she had lost her uterus to cervical cancer several years before and had sort of given up hope. And that storytelling around the world inspired her, and she now has a son.
Yeah.
So,
right. See, we just don't know.
The power of storytelling is really quite remarkable.
For sure. It's, I think, so pivotal, right? Because you hear something and it moves you. And where it moves you, like you can kind of guide it, or like a goosebumps feels like truth to me, something like that. Well, we definitely share a love for Elton John. And I love that you mentioned him and David and that story because your work with them is where I wanted to go next with the conversation, into helping gay men to make the decision. Well, they've already made the decision that they want to be fathers, but when they come to you, that must be one of the bright spots on your day, like some of your favorite cases to work with. What does that kind of work do for you as a gay man and a doctor, and to be able to give them babies when you and Mark are not going to be fathers?
No, it's incredibly rewarding. And just in general, pregnancy rates are very high. So it's a very real possibility. So all gay men, if they want, pretty much can't have children today. And it just wasn't possible, 25, 30 years ago. The first gay couple I treated, in fact, was from Santa Monica. It was about 25 years ago. And they came to me to ask if I could help them. And they were going to use a sister of one of the guys to be the egg donor, and their neighbor down the street was going to be their surrogate.
Okay.
Because this was much less developed back then. There weren't egg donor agencies. There were a couple surrogacy agencies. But surrogacy agencies weren't, helping the gay community. In fact, it was very controversial at that time whether the infertility community should be helping gay men have babies. And so, first I talked to my partners and said, what do you think? Can we do this case? Because it really hadn't been done very much. And they said, yes, we support you if you want to do this. I called my mentor from the University of Pennsylvania, And I said, Jerry, this is my situation. Is it okay to treat this couple, or am I going to get ousted by the reproductive community? He said, let me think about it overnight. I'll call you tomorrow.
Mm.
So it's like, whoa, he's definitely taking this seriously.
Mm-hmm.
So he called me back the next day and said, Guy, treat your patient.
Oh, that feels so good.
And that was the first case. And it was
Wow.
really beautiful. It turns out
Yeah.
the sister was 41, the egg provider.
Oh, no.
So that was a little challenge. We talked about that.
Here's this good story and oops.
But they got, we created embryos. They got pregnant the first embryo transfer. So it was a happy ending.
That's great.
And so since then, we've helped thousands of men from across the world have babies through egg donation surrogacy. And every surrogacy agency is opened up to the LGBTQ community, of course. We have egg donor agencies. We have resource fairs. I'm on the advisory board for Men Having Babies, a nonprofit that offers international, national resource fairs on information on how men can have babies. So it's exciting and it's very rewarding, because as a young gay boy growing up, my saddest part of being gay for me was always the idea that I could never have kids, and it was very painful. So I never want any young gay man to have to experience that. Today, gay men can get married, they can have children, so we have unlimited possibilities.
Yeah.
So
yeah, as it
beautiful.
should be. It's one of the things Joyce was so enthusiastic about. One of many was the gay rights and all about life, right? And to create a life that was as full of joy and love as possible.
Yeah, she was very supportive of helping people, whoever they were, who wanted children to build a family, to help them build a family.
Mm-hmm.
Because for people who have a challenge to building that family, they're building that family out of love and commitment.
Mm-hmm.
And so what do we need to provide the child? What are our obligations? Love, commitment.
Mm-hmm. Right.
And playtime.
At the core. And so does that mean that you met Mark?
Well, we got together.
Later?
We were in our mid-40s, and you want to test the relationship. Then you're next thing you know, you're in your mid-50s. Like, come on, this is our deadline. And then you're in your mid-60s. It goes by quickly.
Yeah.
So I encourage all my young gay patients, do it now. Don't let time pass you by.
Mm-hmm.
Because men have biological clocks too.
Yeah.
And you want to be young enough to care for your kids, raise your kids.
Right.
So,
and to be able to give that gift after your own personal experience, I can't imagine how full your heart is, like where that wasn't in the cards for you guys. But to have so many of these babies, and I know that they send you pictures and they bring the babies in, and you get to be somehow kind of like uncle.
No, the passion is there, because I see the beauty of it, the beauty of, creating embryos, of, initiating a pregnancy, of, I still get excited when I see that first heartbeat on ultrasound.
Yeah.
It's really beautiful.
Right.
And so,
what was it that directed your life towards fertility in the first place?
Initially, when I went to medical school, I wanted to become a pediatrician because I love kids.
Aww.
And I connect well with kids. I did my peds rotation. I enjoyed it. Then I did OB, and it just blew me away. I think most of us in this field went into this field originally because we loved obstetrics. And so then I was going to do high risk OB. Because I like the complexity, the combination of medicine with obstetrics made it a little more challenging, a little more interesting. And I did my OBGYN training at the University of Chicago in the south side of Chicago, where we saw lots of high-risk OB. And it was challenging, but a little bit frustrating, because in obstetrics, no matter how well managed a patient can be, things unravel very quickly, and it was a little uncontrolled, and I'm much more of an organized, detailed person. And so at that time, this infertility world treatment was just exploding, and it was exciting. It was much more controlled, much more scientific and challenging.
Like you could
And
prepare
so
them and then hand them off.
Yeah,
Right?
it was just the nice little switch to pursue it, and I'm so glad I did.
Yeah, it's still the same. Like you're working like 7 days a week or on call.
Well, we're trying to change that a little bit, but we love what we do. So if we go in on a weekend, it's really not work. We're just going to see a patient for a couple hours.
Right, right. But we have worked really hard. Anybody that's in this field leading up to where we are now, where we're starting to figure out how, I don't want to say to batch the embryos, but
no, a lot of programs batch patients, meaning they start stimulation at the same time, so the retrieval will be around the same time. They do series of patients. In general, that works. We tend to see a lot of patients with decreased ovarian reserve, poor response, and in order to batch, you have to put them on birth control pills for a period of time to get them all lined up together. And some women with low ovarian reserve can suppress their ovaries and they respond even less. And so we don't want to risk that. So we start patients according to what's best for that patient. So we're open 7 days a week. If they need to be seen on a Sunday or eggs out on a Saturday or Sunday, we're there because we don't want to compromise.
Yeah.
So
I remember the first time I did an embryo transfer acupuncture outcall session. I think it was like 2002, and it was Christmas Day. And I had to be there at 6:30 a.m. because the embryo was ready to go at 7:30 a.m. And there was no fooling around. And I was so nervous. And because I'm such an empath, I was feeling all of the couple's nerves. And my job is to bring the calm, right? To bring the endorphins. Right. But that is what happens. The embryos call the shots with respect to the schedule.
The ovaries, the eggs, the embryos call the shots. Less so embryos today because most of our embryos are frozen transfers, and we can, schedule those. But we're so obsessed with the ovaries. Just recently, this past Easter Sunday, I was on call, and I was really working to avoid coming in at Easter for all the staff. And right at the last minute, there was one patient that I wasn't certain what day is the best for her trigger shot to remove the eggs. The data wasn't really clear. The only way I would know would be if I saw her on Easter morning. So I came in to see her because it was the right thing to do. Because it's really all about what's best for the patient, what's best for those eggs and embryos.
Yeah. I think that's how we sleep well at night, because we know that we've done the right thing by them.
Rather than pushing her day and, I can see her Monday. No, it's risky.
Then it's more of a business model. This is a heart-centric model.
Absolutely.
Yeah. We have seen so much. You have, I think, like 10 years on me, but the evolution of the day 3 fresh transfer of an 8-cell embryo, or 5 of those, right? To where we are now with freezing, testing, freezing, and then all of the uterine function tests to do like these mock cycles to optimize the uterine environment for the transfer. So much new science, right? It's not new to us now, but we've just kind of watched we're taking the embryos out to 5 and 6 days now. Right.
Well, when you think about the history of reproductive medicine, it's only 40, maybe 50 years old. IVF has been around for 40 years. So in the history of medicine, it's a really short period of time. And the advancements and developments are all geared towards higher success rates, better outcomes for everyone. And, we've come a long way. The pregnancy rates when I started 30 years ago were about, 15 to 20% per cycle. And now for our patients, putting in a genetically tested embryo back in the uterus, we're 75% per cycle. So it's a completely different picture.
Yeah.
And we have more information on the embryos. The genetic testing, PGTA, allows us to screen out those embryos having an abnormal number of chromosomes because that embryo can look beautiful in a petri dish, grade AA, but yet be missing a chromosome or having an extra chromosome, preventing it from resulting in a healthy live birth. So today we can identify the safest embryos to transfer, those with the highest pregnancy potential and a lower miscarriage risk.
Yeah.
So that's been a tremendous advancement. And we no longer do fresh embryo transfers. We do all frozen transfers because when we used to do a fresh embryo transfer, we were putting that embryo back into the uterus coming off a stimulated ovarian cycle. So the hormone levels were not natural. They were elevated significantly. Yeah. And that we found after years that it shifted the window of receptivity of the uterus. So the uterine lining wasn't as receptive to that embryo. So maybe those embryos weren't attaching, not because there was a problem with the embryos, but because the uterine lining wasn't as receptive as it could be.
Right. And remember when you attended my live seed workshop and I was talking about the inflammation post-retrieval. Remember, I was giving food suggestions for reducing the bloating and talking about acupuncture and how important it was right after the retrieval, like a day later, to get the extra water out and bring down inflammatory proteins. And you said, oh, that's right, because we are really poking away at the ovaries. And so keeping the conversation open to all these different ideas being exchanged has really morphed the medicine to change that percentage of the success rate, right? All the different...
Absolutely. And, we used to, as you mentioned, put in 3, 4, 5 embryos because we didn't know which ones were normal, which ones had the potential to implant. So the genetic screening enables us to identify, yes, this one has the potential. We can't guarantee it, but it has significantly higher potential than that embryo right next door to it. So,
right.
So we can avoid the risk of a multiple birth twin pregnancy.
I can't tell you how many sets of triplets have come through the women who did the seed program prior to the freeze-all.
Oh, really?
Because we were improving the quality of the embryos, and then they were just putting in 3, 4, 5 blastocysts. And I have a couple of those.
Yeah,
and
now we're mostly single embryo transfer just because we are able to achieve a high pregnancy rate, but we can avoid the complications of a twin pregnancy.
Yeah, I think what we should say here is it's that time spent optimizing to, as much as possible, create the normal genetics, healthy outcome, right? Like all of the do it quick things. Maybe what I'm trying to say is having the patience while you're optimizing, because we used to be able to do 8 or 10 IVFs. Back in the day, the woman would get her period, she would be stimulated, the eggs would be retrieved, we'd put them back in, and if it didn't work, okay, she's on her period, stimulate the eggs, retrieve the eggs. Now there's a lot more of this testing, scrutinizing, using the technology, but the idea is optimal conditions are being created.
Optimal conditions, for the embryo to be the uterus, even in the IVF laboratory, just the conditions have changed, that developments have allowed us to keep the embryos alive longer, from 3-day culture to a 6-day culture. And today, 60, sometimes 70% of the fertilized eggs will develop into a blastocyst, which is the developmental stage an embryo must reach if it's going to have a chance to implant. So 5 years ago, we couldn't keep embryos alive that long and to enable us to do what we can do today. But due to changes in the culture media, the laboratory environment, we are able to keep the embryos alive longer.
Yeah.
So lots of advancements.
Oh, yeah. That email I was telling you about earlier, this woman I heard from recently let me know that her day 7 blastocyst, it was the 4th of her 4 normal embryos, or no, they were untested embryos. And this was the one that was on day 7. And she said in the email that she was not even going to implant it. But something that she picked up on in the Seed movies made her think, why not? I should just try it. And now she has a 2.5-year-old little girl.
Beautiful. Beautiful.
Yeah. I mean, those day 7 embryos, they still have.
Well, we know they have lower pregnancy rates than day 5, day 6, but we have live births from day 7 embryos.
Mm-hmm. Just like the low-level mosaics. That's something we could talk about too.
Right. When we do the genetic testing, it ideally tells us either normal, abnormal, but sometimes we get something in between.
Mm-hmm.
So when the embryologists biopsy an embryo for genetic testing, they're removing 3 to 6 cells from the outer layer of this 100+ cell embryo, and these are the future placental cells. We're not touching the future fetal cells, and then they'll test those cells in the genetics lab. And if more than 80% is read as normal, it's a normal embryo. If more than 80% of the cells are abnormal, it's an abnormal embryo. Well, what if it's in between? 40, 50% are abnormal. That's called a mosaic embryo. And so what that means is either that the embryo has a mixture of normal and abnormal cells, or it could be that the fetal tissue is entirely normal, but we happen to biopsy a future placental cell that had an abnormality. Because the placenta is this mass of rapidly dividing cells, and you can occasionally have an aberration, and that abnormal cell could die off or be corrected. So it may not represent what's going on in the fetus itself. So today we have quite a bit of clinical experience with the transfer of mosaic embryos, and many healthy live births because of it.
Mm-hmm. Yeah.
So
it's encouraging.
So we're learning. We continue to learn, continue to refine our pre-implantation genetic testing to learn what's safe, what's not safe. And we want to gain as much information as we can so that we can identify which embryo in that petri dish is capable of resulting in a live birth. But we don't have the perfect test yet. Right. Yes, we can tell which ones have the correct number of chromosomes, but that doesn't tell us everything. We don't have the perfect in vitro test to tell us which embryo will result in a live birth.
Mm-hmm. Yeah. We also have those genetic probes if you know that the parents have an issue that they want to screen out.
If the egg provider, sperm provider have a mutation for recessive genetic disease, we can identify which embryos are affected by that disease, because 1 in 4 of those embryos will have the disease. And so in this way, we can minimize the risk of disease in the children. Mm-hmm. So all couples today, before getting pregnant, definitely before doing IVF, should have genetic carrier screening to make sure they don't share a mutation.
Right. Yeah.
And the latest advancement available this year is to do whole genomic sequencing of embryo. Mm-hmm. So rather than just evaluating a couple of cells, we're going to know the whole genomic sequence. Mm-hmm. So it should make the PGTA a little more accurate, and they can tell us which embryos may have risk of hereditary cancers, neurodevelopmental disorders. So they can tell us additional information about the future health of this child.
Yeah, this is
so it's fascinating.
So fascinating. I wanted to ask you briefly your thoughts on the uterine screening, like the EFT, ERA, Receptiva, primarily. Those are important tests, but time, it delays the time before they can put the embryo in, but there's important information that comes from all three of those. Which ones do you like to use and why?
Right. The uterine evaluation is very important because we're creating these embryos, we're genetically tested them. In order for them to have the best chance of implanting and starting a pregnancy, we need a receptive environment. And so in the natural ovarian cycle, there's a 1 or 2 day window when the uterine lining is receptive that will accept an embryo. If you put an embryo in any other time in the cycle, it won't implant to start a pregnancy. So the endometrial receptivity assay, the ERA, identifies how many hours of progesterone a woman's uterus needs to be in that most receptive part of her cycle, the window of implantation. For most patients, it's about 120 to 124 hours. Some women need additional day of progesterone, 148 hours, 144 hours to be receptive. So it's a way to define the best protocol for the patient before you put in an embryo. Now, this test was developed for women with reproductive failure, women who have gone through multiple failed cycles. And now you can do this test that will tell you, yes, she needs a different amount of progesterone, and you can correct this problem. So we've been using it for those cases, as well as in cases where we only have 1 or 2 embryos. We don't want to have multiple failed cycles and then go and do it. So we're doing it before doing an embryo transfer, just as an insurance policy to confirm what dose of progesterone is giving us a receptive lining.
Yeah, you don't want to. If the patient has several normals, it's okay to try putting one in and just see what happens, because they've already waited so long.
For 90% of patients, the standard protocol of estrogen and progesterone, with the embryo being transferred after 120, 124 hours, for 90% of patients, that's the appropriate protocol to give us a receptive lining. So.
Yeah. And then by comparison, the Receptiva DX.
Receptiva is a specialized test. It's also a biopsy done in a mock cycle to test for the presence of endometriosis or inflammation in the uterine lining that could interfere with implantation. Some women with endometriosis have a marker that causes progesterone resistance, and that can interfere with implantation. And so if this biopsy tells us we have a positive Receptiva, then this patient will benefit from one of 2 options, either doing surgery to treat the endometriosis by laparoscopy, or by using a medication called Lupron, where we turn off the natural cycle for 2 months to suppress any endometriosis, and then proceed with the frozen embryo transfer. And the clinical studies show significant improvement in outcome in women with a positive Receptiva who do the Lupron treatment for 2 months before the embryo transfer.
Just to get everything quieted.
Correct. And of course, we want to make sure the anatomy of the uterine cavity is normal, that we have a normal shaped uterine cavity that's free of fibroids in the cavity, free of polyps. Want to make sure there's nothing that could interfere with that embryo attaching.
Yeah. And sometimes there are women who have kind of fulminant endometriosis, and surgery is indicated for them plus Lupron, right? I know,
exactly.
2 to 3 months.
And for women, who don't have a normal anatomy of a uterus, or don't have a uterus because of prior surgery, surrogacy is a wonderful option. That provides an optimized environment for that embryo.
Do you do an ERA on the surrogate typically?
Only if they have 1 or 2 embryos.
Okay.
Similar principle, just as insurance policy, just to confirm. But if we have multiple embryos, I'll do our standard protocol, because that should give them a receptive lining.
Right. And then by comparison to those 2, those are more commonly done uterine evaluation tests. But what about the EFT endometrial function test? I love the idea of that test because my background is in molecular biology, and ironically, yeah, I love the microscopic aspect and to see and to know, oh, there's pathology and there's cyclin E and all of the stuff. But I know very few REs do the EFT. It's so nuanced and maybe controversial. Could you explain why it's controversial?
Now, I personally don't use the endometrial function tests very often. I have in the past. I haven't personally found it that helpful. I know some of my partners do the test, and it has a loyal following amongst some practitioners.
Yeah.
I personally haven't found it that helpful.
Yeah. Okay. Fair enough.
You know, I had a patient once. Her test result, said that she'll never have a baby with, because she needs
the
a
EFT,
surrogate.
her soil was not
it was so
fertile.
bad that she needed a surrogate. And we talked to them about surrogacy, and they explored it, and they came back. And they said, we just don't feel comfortable with surrogacy. I want to transfer my embryo. Transferred her embryo. She got pregnant, had a full baby. Had full-term baby.
Oh, good.
So, but maybe she diverted her energy, right? And she willed that to happen.
Right. So, well, we will never know. But if we call that test the soil test, and here I am, Miss Seed, Garden, right? Fertility, all that. Well, the uterine lining in the metaphorical sense is the lining of her second heart and how she feels about her life. So I would love to do a study. Of course, I'm not going to, but to see happier women having a happier uterine lining, the happiness in her relationship and where she feels like she's at in life. Does that make for a more receptive uterus?
I think it's a great idea. One of our former lab directors said, "Oh, the happy patients always get pregnant."
Right.
Yeah. And those that can approach it with a positive, and I think there's a lot of truth to that.
A lot of truth. And it's hard if they're a patient who's listening and their story is particularly complex and losses or very tragic outcomes. Like, we're not saying that you're not being happy enough. But it is really true. I think that if we say, I'll be happy when I see this outcome, that's by definition despondency. It's to be so focused on what's not happening. And the molecules of emotion, that's a tested science that's out there, where those neurohormones are in the circulation, and that's not a fertile environment.
It's not going to be helpful. We need to redirect that emotional energy, right? And that's what you're so good at.
Yeah. But thank you for acknowledging that and not raising an eyebrow or changing the subject, because the women, if we have two hearts, it really is important that we feel good about the lives that we're creating, because that's the starting point for the future generation that we're building.
Yeah, are you familiar with the book, The Happiness Project?
Not really, but the idea.
Wonderful book, well-researched about happiness, and how people can achieve happiness and active things that they can do to lead a happier life. It might be good background reading for your project, your next study on the happy uterus versus the unhappy uterus.
Yeah.
And how can we convert them to the happy side?
Yeah. It's such a nuance field that we're working in, but the science is there and technology is driving all of it to be a little bit more controlled and certain. I think all the time we're definitely seeing that after all these years and thousands of patients, right?
Yeah.
So
we're so fortunate in Los Angeles to have access to you, as a complement to what we do on the scientific side. What happens in other cities, other parts of the country? How can they gain access to you or your type of holistic spiritual
Sure.
acupuncture?
So, well, SeedFertility.com, that is the domain name of the masterclass that we created, and where we have Holistic Guide to Healing Endo, and Healing After Loss, and an egg freezing preparation course. Like, we've been putting this repository of things together for just that, somebody who doesn't live here in Los Angeles. But the reason I'm putting this podcast together and interviewing everyone here in LA is to hopefully move the conversation around the world. And the way that that will happen is by the patients getting ideas that they heard on a podcast, and then they mention it to their doctor, who might be progressive or open-minded or curious or young and like cavalier or willing to try something different. So, yeah.
You brought up egg freezing patients. I think there's an interesting idea there, because I see some young women in their early 30s who come in to freeze eggs, no history of infertility or fertility concerns, and then we uncover something. Their ovaries aren't responding, or they have a low AMH, and all of a sudden now they're faced with this issue. And, we should have a program specifically for them, to become more positive. Don't let it go negative. And how can we...
That's what that program is about.
Change their lookout and change their response.
Yep. So we are there. We made that course. We also took it from the standpoint of, hey, listen, you're going into a infertility clinic or you're doing fertility treatment, but that doesn't mean that you are infertile.
Exactly.
And the protocols, remember when the egg freezers first came on the scene and we were using the stimulation protocols that had been used for the infertile cases, right? And so the egg freezers were swelling up and having such a hard time after the retrieval, because they hadn't become practiced at one retrieval after another. So a very different mindset for that patient population.
I'm glad to hear that you're
on it.
You're on it.
Yeah.
Good work, Danica.
Yeah.